Same physical examination. So first you have to check for history. See, there is difference between you two and the people who are not came. That's why I didn't tell the first thing. Okay, but I will ask you in the exam.
Okay.
The first part is for key items in the history. Okay, all these things they have to ask. We will ask you in exam. What are the things history you will ask? You have to explain. Okay. Next is what? Physical examination. You have to check for nystagmus. Nystagmus is an involuntary jerky movements of eyes. You have to check for nystagmus. Okay. Nystagmus, we will show you how to check for nystagmus in different positions. Next, effect of fixation on nystagmus. Fixation means now if I am fixing towards one thing, whether I am getting nystagmus or not. Okay? Or if there is any nystagmus, see, if I rotate my head, there is nystagmus. Suddenly, if I fix to something, it is getting reduced or it is getting more. You understand what I am telling? See, on fixation, your nystagmus is getting reduced or it is maintaining the same or it is getting increased. You have to check for that. Because there are two types of problems, peripheral problem, central problem. So in case of peripheral, on fixation it may reduce, but in case of central, on fixation, if you fix, your nystagmus may increase or it may be same, it won't reduce. Okay, so to find out, to discriminate between peripheral or central problem, okay, it's very important to know effect of fixation on nystagmus. Next, direction of gaze. Direction of gaze. Gaze means direction of gaze. Which side you are looking? Gaze. Up, downward gaze, upward gaze, downward gaze. Gaze towards right side, left side. Okay. Next, effect of gaze. Effect of gaze. If you are gazing at something, whether it is same, nystagmus is increasing, decreasing, or it is maintaining the same. Next, gait assessment and balance assessment. Because once if there is any vestibular dizziness, it will show effect on your gait and balance. So you have to check for both gait assessment and balance assessment. Now we will go for special tests. There are, first one is vestibular dynamic visual acuity test, head thrust test, head shaking nystagmus, rotatory chair testing, Hall-Pitt disc test, next computerized dynamophostrography, caloric reflex test, electronystagmography. Cut. Of that. Close of that. First one is what? Dizziness. Dizziness means defined as a sensation of purely feeling a tendency to fall. Person will have a tendency to fall. Next is what? Vertigo. It's an illusion of movement where patient describes that they sense the environment. If you are sitting like this, you will feel that environment is moving. You understood? Yes. All this thing is moving. But nothing is moving. But he feels that false moving of environment. Next is what? Disequilibrium, that is off balance. Next is what? Oscilloscopia. Oscillopsia, where if you are seeing like this, I am seeing Abdullah. Okay, when I am seeing, I feel that Abdullah is moving up and down or side to side. He is not moving, but I feel that he is moving. Okay. Yes. Next, nystagmus, that is what? Involuntary jerky movements of eye. Okay. So and physical examination, all these things. Yeah. Balance assessment and all. Now we have to do this. Okay. Can you please cut? So this is common balance test you have to do for people with having vestibular problem. This is to see whether there is a problem. There are three main problems. Benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo. BPPV. One problem in vestibular. The another problem is unilateral vestibular hypofunction. Means one side vestibular functioning low. The another one is bilateral vestibular hypofunction, BVF, means both sides vestibular are working low. Okay. And next problem is fourth one, central lesion, any problem in the brain. Okay, so how to identify? There are different balance tests, okay, and difference between BPPV, UVF, that is upper means unilateral vestibular hypofunction, bilateral vestibular hypofunction, and central lesions. In that first test is Romberg's test. What is Romberg's test? Ask the patient to stand, okay, comfortably with open eyes, then with closed eyes. Okay, so here what is positive? What is positive for Romberg's? Once if I ask the person to stand, okay, with open eyes, there is no shaking or no balancing problem, nothing, he will be normal. Once if he close the eyes, the person used to sway. This is called positive. Okay, positive Romberg's means once if a person closed the eyes, he used to attend loss of his balance. Okay, that is what Romberg's positive. Negative means with open eyes no problem, with closed eyes no problem. No way, no change in the balance means no problem in the standing down. So what will happen? Romberg's BPPV negative. Negative means no problem. No Romberg's positive. Means with closed eyes no problem. UVL acute positive, chronic negative. And BVL acute positive, chronic negative. And in case of central lesions, like in case of a problem in the brain, what will happen? Often negative. Okay, so only in case of unilateral vestibular lesion and case of bilateral vestibular lesion in acute conditions, you will have positive with closed eyes. Next one is same tandem Romberg. Same things will be happen. Okay, tandem Romberg. As a person to stand, keeping one foot exactly in front of the other foot. Okay, and then again closing the eyes. See whether he is having any more variation in the balance. Generally, they will go like that. They can't do actually. Okay, that is positive. Closed eyes, if any shaking, positive. If open eyes, no problem. Closed eyes, no problem. Negative. Okay, so what will happen in BPPV? Negative. UVL, positives, eyes closed. Positive BVL and positive in central lesions. Next is what? Single leg stance. Very easy. Single leg stance. Negative means single leg stance there is no problem. They can maintain. But in case of UVL, maybe positive means they will tend to lose some balance. Okay. And in case of BVL, acute, positive, chronic, negative. And in case of central lesions, may be unable to perform. Means they can't even perform this. They can't even. They will go like this. They can't perform. Okay. Next is what? Gait. Gait, normal. In case of BPPV, if there is any problem, normal. Acute, wide-based, slow decreased cadence. Slow decreased arm swing, no arm swings, decreased, and no trunk rotation. Means generally you will walk like this, no, with arm swing and trunk rotation. But here, in case of unilateral vestibular lesion, they will go for wide base with no arm swing or decreased arm swing with no trunk rotation. Okay, next compensated normal. Next, same acute wide base, slow decreased, no swing. Okay, next, in case of central, may have pronounced ataxia. Means they will go like this. Central ataxia, they will go like this. Okay, and last one. Turn head while walking means ask the person to do head turning while walking. So what will happen? In case of BPPV, may produce slight unsteadiness. Slight, they will have slight unsteadiness. Slight, but they can do that. Okay. Next, in case of UVL means unilateral vestibular lesion, acute may not keep balance. In a chronic, they will compensate with something else. and same BVL may not keep balance, and in case of central lesions may not keep balance and more attacks. Okay, so these are the balance tests you can do in case of vestibular problems. So how many tests? Rombox test, tandem rombox test, single leg stance, gait and turn head while walking. Okay, so this is a scale. Right. Now we are in special test for special test. There are some special tests, 8 special tests for vestibular lesions. Okay, in that first one is what? Vestibular dynamic visual acuity test. Vestibular dynamic visual acuity test. It's a dynamic visual acuity is the measurement of visual acuity during horizontal motion of head. To perform the test, visual acuity is determined first at static, asking the patient to read the lowest line, then oscillate the patient head horizontally at a frequency of 2 Hz. Patients with vestibular shows 3 or more line decrements. Now what to do here is, you know Snell's chart, what you have seen for visual acuity. Visual acuity, there is one Snell's chart. Okay, Snell's chart. It is there in your clinical training. Please kindly refer. So first there will be big letters, small, 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 small. Generally your visual acuity will be 20 by 20. 20 by 20. So make sure that you are making the patient come. Okay. Now here you are going to keep at a 26 meters distance. Okay, or from 20 feet distance, you are going to keep the patient, and you are going to ask the person, okay, to read. No. You are going to keep some chart. You are going to keep some chart here, and you will ask the patient to, what is the smallest line you can read. Okay. After person has read that line, okay, what you have to do, you have to oscillate the patient's head. Patient's head, can you please close your eyes? Okay, then rotate the head 2 hertz at a frequency of 2 hertz, and then ask the patient to open the eyes and see. Generally, if there is any vestibular problem, if he can able to see some line, now this will get reduced, means he can't see this line. It may less than 3. Okay, 3 lines above, more big line he can see, but not that line. If he is normal, no vestibular problem, he can able to see the same line. Understood? If decrement less than 3 means, if he is going to be more, means more letters, big letters he can able to see but not small, then it's a problem with vestibular. Next one is cut. Next one is head thrust test. Someone. No, you be here, I want you. Yeah, better. Keep like this. Head thrust test. This is the test. Yeah, go little up. Why you are coming so up? Okay, head thrust test. You take the photograph there. Head thrust test. No, that one, and down diagram. Press down. Take that. Yeah. Now go up. Yeah. So head thrust test is. This is to test the semicircular canals. Function of semicircular canals. We had 3 semicircular canals: horizontal, that is lateral, anterior or superior, and posterior or inferior semicircular canals. Okay. Now, before doing this test, we have to check for the range of motion of the cervical. Okay, check the range of motion of the cervical and check if there is any pain like cervical spondylosis or anything. You have to check. Then ask the patient to fix it on near target. On near target. Means near target. You can sit in front of the patient. Okay, you can sit in front of the patient, ask him to gaze at my eyes, and what you have to do here is you have to generally the spectacle should be there, whatever he is wearing it should be there actually. Okay, so I ask him to make the person neck 30 degrees neck flexion. Now see my eyes. You must be in a same level to the patient. Understood? Okay, then ask him to fixate on my eyes. You have to fix on this. I will move your head, but you have to fix on my eyes. Okay? So what will happen here when you are moving? If it is normal, so now what you have to do here is ask the patient to focus on target while head is manually rotated in an unpredictable direction using small amplitude, small range with high acceleration, means with high speed with small movement. Then what is the normal response? Normal response is eyes move opposite to the head movement. Means if I am moving your head to the right, your eyes will move towards my left because you are gazing at my eyes. Okay? If it is abnormal, the eyes will move towards the same side. Very simple. Only thing here is check for the neck range of motion and all. Ask the patient to gaze at your eyes or some target. If you are not here, you ask the person to target on something. You be behind the patient, or if nothing is there, you ask the person to gaze at your eyes. Okay. Then make the 30 degrees of neck flexion. Check, and without any unpredictable. Suddenly, if I see, still his eyes are gazing towards mine. Understood? If it is abnormal, if there is an vestibular, these eyes will move towards the same side which I am moving. So this is what head thrust test. You have to do small movement with more speed, unpredictable. Okay? I will explain. You keep it there. So it is useful test to diagnose unilateral peripheral vestibular problems. Means if I am having any problem, vestibular problem on my one side, you can do this test. Very good test for unilateral. Before we have seen one more test, that is for semicircular, that is head thrust test, and this head shaking induced nystagmus is for peripheral vestibular problems, that is on one side. Here you have to ask the patient to close eyes. The clinician flex the head 30 degrees and oscillate. Oscillate means move the head horizontally for 20 cycles. For how many? 20 cycles. Means this is one cycle. 2, 3, 4. Okay? With how many frequency means with how much speed with the two hedges means for 1 second 2 times you have to do. Okay, like that 20. Okay, then stop the oscillation, ask the patient to open eyes and check for nystagmus. Okay, very simple test. So you can be on the front of the patient or back of the patient, but better to be in front of the patient. So you can ask the patient to close the eyes, flex to the 30 degrees and move the head horizontally with how much frequency? 2 hedges means per second 2 cycles. Like that you have to do 20 cycles. 20 cycles. Now I am okay. Then ask the patient to open the eyes and see whether there is any nystagmus. If there is nystagmus, it's a problem in vestibular on one side. Means how you know which side is affected means always the fast face will be towards normal side. Means the eyes will move, no? Jerky movement. There are 2 phases in that. One is slow phase, fast phase. If towards my right, fastly it is moving towards right and slowly it is moving towards left, the side which is it is moving fastly is my affected side. You understood? Yes. Okay. So the side to which side the fast face is moving. Means if it is towards my right side is affected. If my fast face is towards my left side is affected. Clear? Yes. Next. Cut. So rotatrix test stimulates vestibular system by rotating subjects in the dark place. You have to do this test in dark place. In normal people, nystagmus will be generated by the rotations. Normal people, if you make them in a dark place and if you rotate, it will give some nystagmus. But in vestibular disorder, okay, there will be some. If you compare VOR means vestibulo-ocular reflex gain, and phase of 1 year with the other may be okay within or comparing within normal values. Okay. So what you have to do here is you have to make the person in a dark room and rotate the chair. Closing the eyes, rotate the chair. Okay. So what will happen? Generally we will have some nystagmus, but if it is an abnormal vestibular disorder, you can see some difference between right and left in vivo vestibulo-ocular reflex gain. Maybe Dr. Faisal might have explained you about this vestibulo-ocular reflex gain in his theory. Okay. Next, very important test we will go to see, that is Hall-Picke-Dick's test. Go down. So here, Hall-Picke-Dick's test, keep it there itself. Ask the patient to sit on examination table. Okay, turn patient head horizontally 45 degrees. So, now show you. So you have to turn the patient head horizontally 45 degrees and quickly brought to a supine position with neck maintaining 30 degrees, of extension. Okay. Check for nystagmus and ask for vertigo. Then slowly bring the patient to sitting. Then perform to the other side. Okay. Now move little down and show that picture. What they are doing. Okay. Now how to perform this? Okay. Now, yeah. So you have to turn the patient head to the 45 degrees. Okay. You be in long sitting, better. Which side is better for you? This side or this side? This side. No. Why you are lifting that? No, that. Okay. Supine means long sitting. No. Okay. So long sitting. Yeah. Can we come little back? You to come. So now here you have to turn the 45 degrees. Okay. Be here and get into the 30 degrees. 30 degrees of extension. And you have to check for any nystagmus, or you have to ask the patient for any vertigo. They will feel any vertigo. Then slowly, once if vertigo or if there is any nystagmus, let that come down. Then slowly get the patient to the sitting, and then again check on the other side. You have to check on the other side. 45 degrees and maintain the neck in an extension of 30 degrees. Maintain this 45 degrees and again check for nystagmus and ask the person for any vertigo. Okay. So you have to wait at least for 45 seconds to get that if there is any nystagmus, to get it settled down. Then slowly get the patient, wait again here, check for any nystagmus, then get into the neutral position. This is what Hall-Picke-Dick's test. Okay, cut. Reflex test, caloric reflex test. See, What is caloric reflex test is, if you put some, caloric reflex test, it all depends upon hot water and cold water. Okay, so if you are putting some hot water, okay, it will your eyes will turn to the same side. If you are putting cold water, your eyes will do on the opposite side. This is normal. If anything going opposite to this, then it is abnormal. Hot water, if I am putting hot water into my right side, my eyes will move towards the right side. If I am putting cold water, my eyes will move, means on the right side, it will move on to the opposite. If it is anything happen opposite to this, then it is an abnormal. That's about caloric reflex test. Now just keep it like and move little down. So these are all some outcome measures. Outcome measures: head movement visual unlock scale, then functional disability scale, move it down. So 0, no disability, negligible symptoms while doing these tests. If you are if you are doing some function, okay, while doing a function, how will you scale? How will you score? Yes. Okay, the problem here is 0, there is no disability, negligible symptoms, no vertigo, means negligible, very less. 1, no disability, bothersome symptoms. No disability, you can do the function, but the symptoms, you are getting more dizziness and all. Okay, bothersome, it is affecting your psychological thing. Next 2 is mild disability. Mild disability means when I am doing some functions, I am feeling little mild disability in doing functions. At the same time performs usual, but you can perform your usual duties. Means you can get into the car, you can come to the, but you may feel some slight disability, no? Okay. Next, moderate disability, disrupts usual. Disrupts means it will affect you. You can't come by car with your own. You need some friend, to get you here, and you can't get alone into the lift. You need someone's help. Okay, understood? Yes. Next is what? Recent severe disability, medical leave. You can't do any movement. Okay, it will be very hectic. Means you can't do any activity. If you are doing, you are getting vertigo, and you may get some nystagmus. You may feel some disequilibrium. So you will be in home. You will be medical leave. 6, severe disability. Even little movement, you can't do any movement. No function, no roll. Even you can't roll. So that much bothersome it will be. Okay, so this is how you can grade the functional disability scale for vestibular. Next, this is a dizziness handicap inventory. Here there are 3 things. One is P. Okay, P means, 1 minute. P means physical function. There is one more F. You can take it. You can't take it. There are 3 things. Okay. P, physical function. E, emotional subscale, and F, physical subscale. Functional subscale. So functional, emotional, and physical subscales. So you have to give grading for all these things. Emotional means how, whether he is feeling fear or not. So this is the subscale you can use for, okay, disability handicap inventory, dizziness handicap inventory scale. Okay, so this is about assessment. Next we will go for treatment.
Okay.
Management. It is the otoconia will be written into vestibular, means there are some particles which you have to get again into original position. Because they came outside, you will feel all this disturbance. So otoconia will be written into vestibular. The patient will demonstrate reduced vertigo. The patient has to improve in balance. The patient has to improve in decision making skills. The patient should be independent in daily living activities. You have to come by your own to the JAMA with the car driving and all. Okay, so independent will be improved. Next is what? Intervention. Cannulate repositioning manual. It is to move the debris. Debris means waste which is present in the semicircular canals. You are going to move the waste subject. Can you see that arrow mark? arrow mark in the semicircular arrow marks are there, no? Black color arrow mark, black arrow marks. So that shows debris. Keep it there itself. This is the debris. Okay, you are moving that debris again into you are draining out, or you are making again into that particular position. So that is what you are doing in canalith repositioning manual. Okay, so canalith repositioning manual, I will just explain. So there are two canalith repositioning manuals, very important. The first one is for anterior or superior or posterior semicircular canals. If there is any problem in anterior, okay, or posterior semicircular canals, you will this manual. There is one more manual which is in down for horizontal. First we will see for superior or anterior and posterior semicircular canals. So here the patient head is turned 45 degrees towards involved side. If my right side is involved, keep it there. If my right side is involved, I have to rotate my head. I have to rotate the patient's head to the right side 45 degrees. Then the patient is then moved into Halpic disc position with involved ear towards ground. Means if my right ear is affected, I have to turn the patient 45 degrees and you have to make the patient head to touch right ear down into 30 degrees. Maintain 30 degrees of neck extension. Turn patient head to 90 degrees towards opposite side. The patient is rolled over to opposite side. Then slowly bring the position to sitting. Maintain head in 45 degrees to opposite side and apply. Now what you have to do here is, so now we are doing canalith repositioning manual for superior or anterior and posterior semicircular canals. Okay, as per Halpic disc test, okay, you have to turn. Let it be this person is having this person is having a complaint on your examination. You find that he is having problem on his right side. Right semicircular canals are affected. That is either it can be anterior superior or posterior semicircular canal. So first of all, you have to turn the head 45 degrees towards the affected side. Okay, and check for any nystagmus or anything. If not, get the person into Halpic's disc position. Okay, with 30 degrees of neck extension. See for any nystagmus or anything. Wait for 45 seconds. Then turn the patient head towards the 90 degrees, means towards the other side. Maintain it in an 30 degrees of extension. And again check for any nystagmus or anything. Then slowly maintain. Then slowly get the patient to the sitting. Keep it here. Why you are doing? Okay? Keep in 45 degrees and again check for nystagmus or anything. Then if it settle down, slowly get the patient into the normal and put soft collar to avoid further range of motions. Okay? So this is what canalith repositioning manual. Cut. So here next is for horizontal semicircular. If there is any problem in the horizontal semicircular canal, this is the same canalith repositioning manual for horizontal. First we have seen for anterior superior and posterior. That is, it can be anterior superior or posterior semicircular. Next is we are seeing for horizontal semicircular canal. In that, initially maintain neck in 20 degrees of neck flexion. 20 degrees of neck flexion. You down. We will finish that, then we will show. Then patient has to lie down. Patient has to lie down with 90 degrees of rotation to involved side. Means if it is right side, you have to see that patient has turned to 90 degrees of rotation to the involved side. Then rotate 90 degrees towards the opposite side. Then you have to turn the patient head, rotate towards the opposite side. Wait for 15 seconds or till symptoms vanish. Then rotate 90 degrees towards opposite side. Wait for seconds or till symptoms vanish. Maintain 20 degrees of neck flexion. Roll patient to prone. Okay. So this is for horizontal semicircular canals. So what you have to maintain here is you have to maintain the patient. Can you please come? You have to maintain 20 degrees of flexion. Okay. Now starting is initially if his right side is affected, I have to turn his head 90 degrees towards 90 degrees towards his affected side, right side. See for any symptoms. If not, if it subsides, then slowly turn the patient head towards 90 degrees towards the opposite side, and again check for any nystagmus or any complaint of vertigo. Okay, then slowly ask the patient to turn his body, okay, to the affected side. Can you please turn? Yeah, turn. Yeah, that's so. Okay, then again check for any nystagmus and wait for 45 seconds. Then maintaining the neck in an 20 degrees of flexion, turn to prone. 20 degrees of flexion, prone. No. 20 degrees of flexion. Okay, and again check for any nystagmus and ask for any this thing. So this is how you have to do for canalith repositioning maneuver for horizontal. Okay. Respiratory or cement maneuver, it is move the debris out from semicircular canals. Okay. Here also, come down. So here is the description of liberatory cement maneuver. Patient's head is rotated to 45 degrees to the opposite of involved side. Now, if I am having anything on my right side, I have to rotate my head towards my left side, 45 degrees. Okay, opposite to the involved side. Bring patient to side lying. You have to bring the patient to the side lying from sitting position and wait for 1 minute. The patient is then rapidly moved to 180 degrees to the opposite side, keeping head down, in the same position, down. Okay, so that is about liberatory cement maneuver. Make the patient in a sitting position. Okay, so now let it be his right side is affected. Now I have to do 45 degrees of rotation towards the 45 degrees of rotation towards the
affected side.
Opposite to the affected side. Now the right side is affected. I am turning his head towards left side. Then you have to get the patient to the side lying with the skull. Okay. Now check for any nystagmus and vertigo. Once it is settled down, keep your legs down. Now suddenly, with so much of force, you have to get to the affected side and see for any nystagmus and vertigo. If there is anything, let it be subside. Okay, then slowly get the patient to the normal exercise where patient will do. This is an exercise where he can do it in his home. So it is for habituation and to move the debris out from semicircular canals. It is the habituation. These are the habituation and to move the debris out from the semicircular canals. Okay, then as the patient rotate head to one side for 45 degrees, it is not affected our normal side. To any side he can rotate his head to 45 degrees. Advised to go for quick side lying onto the opposite shoulder. If I am turning the head to the right side, he has to lie on his left shoulder. Okay, left shoulder. Then ask the patient to maintain it for 30 seconds. Next, patient has to come to upright sitting position, slowly maintaining head in the same position. Then repeat the same steps toward the opposite side. Now how to do this here is, okay, now turn your head to the right, left, okay, left. Now you have to lie down on this side. Keep that head like that. Keep like that. Okay. Then check for nystagmus if anything, and let it be come down. Then slowly come to the normal. Keep your head like that. Come to the normal. Then see for any nystagmus if you have anything. 45 seconds. Then come to the normal. Okay. Then to the. Okay. This is what habituation Bandroff exercise. Okay. You can do it for one time if you are doing, do it for 3 to 4 cycles. One cycle means you are turning to the left and you are going on to your right, coming up, then again come, then again going, and coming up and do. This is one cycle. Like that, how many cycles? 3 to 4 cycles per one session. It all depends upon the therapist. Okay, based on the patient's condition, he can tell how many times he has to do. But for one session, better to go for 3 to 4 cycles. That is about Bandroff exercise. Make it fast. Put it down. I think a lot of things are there. Then that is about BPPV, where bilateral. See, this 3 exercises. No, not this one. First 3 exercises. See, keep it to me. The first 3 exercises, that is Canalith repositioning, liberatory cement maneuver, and Bandroff exercise. These 3 exercises are for BPPV, that is benign paroxysmal positional vertigo. If I ask you the treatment for benign paroxysmal positional vertigo, you have to show me these 2 maneuvers and 1 exercise. Okay. Next is for unilateral vestibular hypofunction. Okay. So the goals are to maintain stability of gauge, to improve, to demonstrate diminished sensitivity to motion. Patient will demonstrate improved static and dynamic postural stability. Now intervention. Down. Visual vestibular stabilization exercise. Visual vestibular stabilization exercise. Here the progression. This is an exercise which is having 3 paradigms. P paradigms. Okay. Can you show the diagrams? 3. 1. There is 1, 2, and 3. 1, 2, and 3. Okay. So this, how to do this? What are the things you can change? You can change as you are progressing. As you are progressing is duration. You can change the duration of the treatment. You can improve the background and distraction. Next, position, speed, frequency, and distance from where you are doing this treatment. So this is a very simple treatment where you can have an visual stabilization exercise. First, you have to focus on one thing, okay, object with certain distance, and you have to turn your head focusing on that. Okay. Next, you have to focus, and you have to move the object without turning off your head. You have to focus on that. How much you can able to do, you have to do it without turning your head. Okay. Next, third one, you have to move the object in one direction and you have to move the head in one more direction, making the gauge on the pen. Okay. So I am moving head to the one side and turn to the opposite side, gazing on that. Okay? So these are the three paradigms for visual vestibular stabilization exercises. Okay? You can improve based on duration, background, position of your position, then speed, frequency, and distance of object. Okay? Next. Next is some postural stability exercises. Can you move little up? This is the table. This is the table which shows a different. This is the table which shows. These are the postural stability exercises which will help you in improving the balance. So first to begin with and progress. First column is begin, progress, and what is the purpose. First one is what? Stand and feet shoulder width apart, arms across the chest. See, this is the shoulder width apart, foot with arms across the chest. Okay. Then bring the feet close together, close eyes, stand on sofa or cushion. This is cushion. You can stand on cushion. So you, okay, understood? This is the first one in postural stability exercises. It will enhance your vestibular cues. Okay, eyes closed, you will rely more on vestibular. Second one, practice ankle sways, medial, lateral, and anterior posterior. So practice ankle sways. Okay, so this is anterior posterior and medial, lateral sways, medial, lateral sways. Okay, doing circle ways with closed eyes, Okay, so this will again help you to correct ankle strategy. Next, attempt to walk with heel touching toe on film surface. What you have to do? You have to like this. This is what tandem walking. Okay, like this. Do the same exercise on carpet. One is film surface like floor, another on the carpet. Once if you are walking on the carpet, your proprioception will get less, so you have to depend on vestibular. Okay. Next is practice walking 5 steps and turning 180 degrees. Practice walking 5 steps, 1, 2, 3, 4, 5, and turn 180 degrees. 180 degrees this, 180, okay. Then again walk 5 steps, okay. Then again turn 90, 180, then again turn. So you can turn on to right or left, different. Okay. Then make smaller turns with closed eyes. Make 1, 2, 3, 4, 5. Make smaller turns with closed eyes. If you close eyes, you have to depend on your vestibular system. So you are going to improve your vestibular. Okay. Next, walk and move the head side to side, up and down. Walk and move the head side to side or up and down. Up and down or side to side. Now counting backwards from 100 by 3 means when you are walking, okay, you have to count 100. Minus 3 how much? 97. Minus 3 94. Minus 3 91. Minus 3 88. Like that you have to count. You have to do the activity and you have to calculate. Okay. So that is what exercises. Postural stability exercise. Next one is last one, habituation exercise. Catherine, you take this. Catherine Kruske exercise. Okay. In that first one, eye movements. At first slow, then quick. Do it fast. Here, give me your steps. Do this. So in bed or sitting, these are habituation exercise, Catherine Kruske exercise. First one is in bed or in sitting position, eye movements, first slow, then quick. Do your eye movements up and down, up, eye movements here. Don't do a neck, up, down. Okay, then from side to side, Okay, then focusing on finger. Focusing on finger 3 feet or to 1 foot away from the face. Focusing on do the same thing with focusing on this. Do the same. Up and down. Down. Side to side. Focus on this. Okay. Next, head movements at first slow, then quick. Bending forward, backward, side to side. Then sitting, second one. Show them. Second one, sitting, eye movements and head movements as above. Then you have to add shoulder shrugging and circling. Shoulder shrugging and circling. Circling the back and front. Yes. Next, third one. Show that. Let it make it little down. Okay, now we are in third one. Yeah, wait. Third one, eye, head and shoulder movements as before. Eye and means you have to do up and down, sides, then head flexion, back, side to side. Okay? And shoulder movements, shrugging and circling, back, front. Then what you have to do, changing from sitting to standing position with eyes open and shut. Changing from sitting to standing position, sitting to standing position with open eyes, okay, and with closed eyes. Next, throwing a small ball from hand to hand. You take the small ball, let it be a ball, okay, throwing it from side to one hand to the other hand. Okay, next, throwing a ball from hand to hand under knee. Okay? No, it's open eyes. Next, changing from, if you want to make it more complicated, you can do it with closing eyes. More vestibular. Okay? Next, changing from sitting to standing and turning around in between. So, sitting to standing, turning around, and then again sitting. Next, fourth one. Moving about in class means circle around the center person who will throw a large ball and to whom it will be returned. Means, can you please come here? Take this. Now you move. I will be here. You move and throw that. Okay? Okay? So this is what? Circle around. Next, walk across room with eyes open and then eyes closed. Walk across the room. Okay? Across the room like this with eyes open and then with eyes closed. Next, walk up and down slope. You know slope? Ramp. Walk up and down slopes with eyes closed and eyes. Okay. Next, steps. Walk up and down steps with eyes open and then eyes closed. Then any game involving stopping, stretching like playing volleyball or football, those kind of games you can. Okay. So and you have to maintain some cardiovascular endurance. Next, down. That is for unilateral vestibular hypofunction. Next is what? Vestibular, bilateral vestibular. So reduce the compliance, improve the static and dynamic balance, independent in performing. And here, same last. Visual stabilization exercise, central eye programming. This is central eye programming. You have to begin with hold two. You have to hold. Keep it. Hold two targets at arm's length from your head. Look with your eyes first. Then turn your head towards the target. Attempt to do this for 60 seconds. Okay? Like this. Can you show them? Two targets. Okay? Two targets are there. Then you have to turn your head towards the two targets for 60 seconds. Okay? And what is the progress of that? Progress to increasing the distance used to see the target. Now I am doing here. You take the target there. more distance and ask him to do it targeting from the more distance. Okay?
Yes.
Or you can use a checkerboard. Checkerboard means, you know, chess. Generally there will be black like that. So that background will give you some more discriminations, some more complication to focus on target. So you can use that background. Okay? Next one is perform exercise 1 in the vertical direction. Now the targets are there, up and down. You have to do up and down, up and down. Then same as above, you have to increase the distance of the target to more and do it with some complicated background. Next, third one. Down, make it down, Abdullah. This is the last one. Hold one target at arm's length from your head. Close your eyes and turn your head away from the target. Attempt to keep your eyes focused on that target. Open your eyes only after having turned your head. So progress doing this. So first you have to do it in sitting. Okay? No, I will do. Same thing. What you have done. So you will focus on the object. Before you have done with open eyes. Now you have to close the eyes. You have to see that your eyes must be focused on the object. This is the center. Then again focus on that object. Your eyes. Can you see my eyes? Balls moving that side. Eyeballs. Okay?
Yes.
Then open the eyes to focus. Okay? So first you have to do with the supported sitting position. Then you can do it in standing position. Okay? So this is the progress. This is visual vestibular stabilization exercise for bilateral hypofunction. Okay? So with that we have finished the vestibular part. Okay? Thanks.